All right, everyone, welcome to our Ask the Expert interview series. Today we have Jennifer Gendeman, a low vision specialist, on with us that we work with quite a bit. So thank you for being on here today, Jennifer.
Thanks for having me.
So February is Age-Related Macular Degeneration Month, as well as Low Vision Awareness Month. So we thought that this would be a perfect time to have Jennifer back on with us, just to go over some specifics on AMD and then just some general information on low vision and the types of services that people like her can provide. So we'll kind of jump right in. But I read a recent article about AMD, and that it's the top cause of critical vision loss and legal blindness in adults over the age of 65 in the US. And it's expected that by 2030, there will be more than 6 million Americans who will develop the disease. So I just wanted you to first kind of explain the disease, if you don't mind.
Sure. And I think those numbers are pretty accurate with what I see too. Most of my folks are dealing with macular degeneration. So it's important, to understand macular degeneration is the thinning of the macula, which is part of the retina on the back of the eye. The macula is responsible for that fine detailed vision, for the reading, seeing faces, very important. One analogy that I hear a lot of optometrists and ophthalmologists and just low vision professionals use to explain it is your eyeball is a camera and the macula is your film. When your macula is working properly, you get those high quality, good images sent to the brain. And when your macula is deteriorating, you're getting a blurry image sent to the brain or one that maybe doesn't make as much sense. So that analogy kind of helps to understand your film may be damaged. And there are two forms of macular degeneration, dry and wet. Dry is the more common form. And it's how I described earlier, the thinning of the macula. There's some increased protein clumps called drusen that happen and cause damage. The wet form's a little bit different. It's a little more aggressive. It's where some abnormal vessels are growing under the retina and they can leak some fluid, hence the wet description of it. So there's fluid or blood that's causing damage to the macula. There's scars that can happen. And again, like I said, this is more rapid deterioration. So we have our wet and our dry, both causing deterioration of the center vision, the fine detail vision.
All right, that's good to know. With more than 6 million people developing it, it's good to get this information out there as more and more people will be diagnosed. So can you tell us if there are any symptoms or signs or things to look for in thinking that you may be developing this?
Sure. One of the first things I hear from clients that are describing macular degeneration or maybe aren't sure that that's what they're dealing with is they describe wavy lines or light poles that are, not lining up possibly. So that's kind of one of the things I hear first. Also just difficulties with reading when they're in a low lighting situation, like a restaurant. They may struggle more with seeing a menu or needing a flashlight in a restaurant or low light. And then just, general blurriness or distortions when they're reading. Sometimes they describe it as words or letters are jumping or they go missing. And then kind of last, early report that I hear is difficulty with seeing faces. And a face is, poor contrast, a lot of features. I have light eyes, light hair, light skin, and it can kind of blend together, if that deterioration is beginning. So those are some of the things that I hear. And a lot of times, an ophthalmologist or an optometrist will ask someone to look at a grid to see if they notice any of that, if they're at risk. So they'll start to see those wavy lines. And sometimes in the early stages, there aren't any symptoms or signs, but an optometrist or an ophthalmologist can see the beginnings of the macular degeneration on the back of the eye during an exam. So that's why it's important, get your yearly exams. And then also knowing that family history. If someone else in the family has it, then you can be watching for it and let your doctor know. So.
Sure. So specifically with age-related macular degeneration, is there a normal age range where people tend to be diagnosed?
So age is the biggest risk factor for macular degeneration. As you age, your risk increases. It's infrequent that they diagnose before the age of around 50. So anywhere after that, it's going to become more common, but the risk increases by 3 times in patients that are 75 or older. So from that 50 to 75, you get a high rate of increase. So aging is the pits.
All right. We've talked about this a little bit, but kind of go into maybe more detailed of kind of the long-term effects of AMD.
So the long-term effect is permanent vision loss, and that vision loss can hinder, your day-to-day tasks such as reading, writing a check, recognizing a face. One thing I always like my clients to understand is if they're dealing with macular degeneration and only macular degeneration as far as eyes are concerned, they will not go completely blind. Their peripheral vision or side vision will stay intact. And they may become what's known as legally blind, but they will never be totally blind. Legally blind is 2200, and that's a definition in their better seeing eye and definition from the government. But, I just like them to know that they'll always have that side vision to work with. And it's, tough either way, but like to put a positive spin on it.
Yeah. So is there anything that someone can do to help decrease their chances of developing AMD?
So we already talked about age, being the biggest risk factor, but there's a lot of risk factors that go into AMD, some that are still being researched more thoroughly. But beyond age, genetics, lifestyle, sex, and race also play a role. So some of those you can control and some you can't. AMD is frequently found in Caucasians, followed by Hispanics and Asians. And then, of course, there's that increased risk with positive family history. So knowing your history is important. The one place that you can make a change is in lifestyle and diet. Smoking is the most influential, modifiable thing, is cessation of smoking. Smokers that are 40 and above have 2 to 4 times more likelihood of developing AMD than non-smokers. So smoking is a big one. And then looking at your diet and your intake of different fats, saturated fats and trans fats are associated with the increased prevalence of AMD. So women are also at a higher risk, and folks with high blood pressure and obesity. So be looking for those lifestyle changes that you can control. If it's caught early or you're aware of family history, you can kind of make those changes. Some doctors will also recommend a vitamin regimen to try to slow the progression and keep your body full of the good vitamin C and omega-3 and antioxidants. So keep yourself healthy, exercise, no smoking.
Are there any surgeries or any type of treatment to help slow down the progression?
So there's no current cure for macular degeneration and no treatment for dry. Again, your doctor may recommend a vitamin regimen or a lifestyle change. But for macular degeneration, they use injections of medication, or rarely they have laser treatments to prevent further leakage and further damage, further growth of those vessels that they don't want to see. Most folks that are on injections are on a 4 to 6 week schedule to get those injections until the doctor's pleased with, the stopping of the growth of the vessel or the leakage. There's also an implantable miniature telescope surgery for macular degeneration. It's very similar to a cataract surgery, but instead of a lens implant, they put a small magnifying telescope in one eye. There are lots and lots of rules. You have to kind of be the perfect candidate for it. They want to make sure that you don't have any wet active macular degeneration. They want to make sure your peripheral vision is intact. You can't have had cataract surgery already. So lots of different things to make you the perfect candidate for that. It's also kind of like monovision. So your telescopic eye is used for detail and close-up tasks. Your other eye is used for moving around. So we have to make sure that you can adapt to that as well. But the hope is that you have a little bit more boost from that magnifier that's in your eye, so you don't need quite as much magnification in a handheld version. But typically folks will still need, devices and assistance, even if they have that telescope implant. So those are some of the options that are out there for treatment, even though they're always looking into more research, lots of research out there for regenerating cells and other implants. So we'll look for that to come down the pike.
So if someone is diagnosed with AMD, it is going to be a big lifestyle change, but it's not the worst thing as far as vision loss that they could be diagnosed with. It's kind of what I'm gathering. If that's the only vision issue you have, you won't go totally blind. It will be eventually a significant lifestyle change.
Sure, there's lots of adaptations out there, and magnification devices, technology, but frustration, of course, too.
All right. So as I mentioned earlier, February is also Low Vision Awareness Month. And you are a low vision specialist, and you've helped us with many patients with low vision. But for those who may not be as familiar, can you tell us if there are any specific requirements or, I guess, abilities that are considered low vision? Legally blind is 2200, as you mentioned, but are there any similar qualifications to be determined low vision?
So the way I think about low vision is just if you have an activity that's difficult for you because of your vision, you are low vision. So, and if your condition can't be fixed with contacts, glasses, treatments of any kind, medicines or surgery, you're struggling with day-to-day tasks, reading, driving. I think of it more on a functional level than on a numbers level with low vision. Of course, insurance companies define it a little bit differently. In order to qualify for low vision occupational therapy, you have to be around 20/60, 20/70 in your better seeing eye. There are certainly some other ways that we can qualify people to make sure they get the services they need. If they have the blind spots, if they have reduced contrast, if they have side vision issues, all of those things also qualify, not just the numbers. But with low vision, I just think of it, you have a condition that can't be corrected to what your vision once was, and now we have to try to adapt so that you can continue doing things that you need to do day to day.
Sure.
So not a real straightforward definition, but I think of the function.
Yep. So it's more of a case-by-case basis and the individual person's vision and ability.
Yeah.
Okay. So after being diagnosed with low vision, or even, noticing those changes of not being able to do what they once did due to vision loss, what are kind of the first steps that a patient should take?
ask for a referral for a low vision specialist. So, keep up obviously with your optometrist and your ophthalmologist recommendations. Oftentimes, if one of your general practitioners sees something, they're going to refer you on to maybe a retina specialist if it's macular degeneration. So definitely follow those recommendations. And then, once they've exhausted any kind of treatment options, surgery, once that's been discussed and exhausted, then ask for a low vision consult if you're struggling with any reading or day-to-day tasks.
Okay. So I think we just kind of hit on this, but when is the best time to start working with a low vision specialist? What would you recommend?
Whenever you start struggling with a day-to-day task because of that vision impairment. So best case scenario is if you're having struggles because of vision, you would first see a low vision optometrist for an assessment of, a glasses RX change or magnification needed to kind of, continue reading or doing day-to-day things, followed up by working with someone like myself, an occupational therapist, where I would help, implement that magnification. We could look at lighting, technology, understand contrast, and sometimes one or more of these professionals or services aren't available, so we try to do the best we can to give you as many adaptations as possible. But also, if you're dealing with wet macular degeneration, sometimes you might need to hold off on that low vision eval because there are a lot of fluctuations happening when you're receiving injections or any treatments. So, if you're dealing with that, and you're getting a glasses prescription, you might end up having to change it a lot of times if you don't wait till you're kind of at a stable point. And we don't want people to have to keep buying glasses. So sometimes when you're dealing with wet, it's best to wait a little bit to see if your treatment is working and wait till you're in a stable point. But again, anytime you're struggling with anything day to day, we can be there.
So what are some services that can be provided by a low vision specialist to help a person with low vision or with AMD, or could be both, but just what are some typical services?
Sure. So the low vision optometrist would complete a trial frame refraction, and that's a glasses check situation. But the trial frame works a lot better for folks that are dealing with low vision or AMD because a lot of times they're dealing with blind spots or reduced field. So the larger lenses make it easier for someone to work with, their best possible vision to get their best possible refraction or glasses prescription. So most low vision optometrists do that portion much differently. They take a lot more time on it. You don't have that phoropter in front of your face. You have more area to work with. They can make bigger jumps in differences between the lenses. So it's a very comprehensive look at whether glasses can do anything to assist. And from there, they start introducing appropriate magnification for near and far. So that's kind of their role. Then you go on to a low vision therapist or an occupational therapist that can provide training with what the doctors introduced, work on adaptations, including technology. And a lot of that work happens at the home, which is beneficial to make adjustments and lighting and positioning. And then there are certainly other professionals out there. There are orientation mobility specialists that can help if you're struggling with safe mobility in your community or using the bus system. There are also, VRT, which are rehab therapists that can train you on Braille and different non-visual training in the home. So if you're someone that wants to tap into other senses, and there's also folks, voc rehab to help if you need to get back to school, get back to work, and pursue any of your vocational needs. So there's lots of different professionals. I'm sure I might have left one or two out as well, but lots of folks out there that want to help you adapt and get back to what you need to be doing.
All right. Is there anything else that you want to share specifically about AMD or low vision, or just your services in general today on things that we've discussed?
Sure. Like I said, I work with a lot of folks that are dealing with macular degeneration. That's the majority of my population. My services are typically covered by your insurance, which is helpful. I come to the home, which is also helpful, and I provide services here in Louisville. Um, I work with, most of the local optometrists and ophthalmologists, and they kind of have a general idea of who I am and will often be more than happy to provide that referral so that I can work with folks. So I have a good working relationship here in town, and I can take care of all that stuff on the back end. And so I hope to work with anyone that's, ready and willing to address any of their frustrations with low vision and macular degeneration. Best way to get in touch with me is either by phone or email. So I will go ahead and share that so that folks can jot it down if they need to.
And while you're doing that, I'll just ask, do you serve patients only in Jefferson County, Louisville area, or do you go outside of that area?
I try to keep my bubble to around 20, 25 miles, which will cover, Shepherdsville, get me just into like LaGrange and those surrounding areas. I apologize. Doing two things at once is not always easy. So I try to keep it to that. I have had some practices have several clients in one area, such as Radkey or, excuse me, that was not right. That's Dr. Radkey. Bowling Green. So they had several patients in Bowling Green, and so I made a day of it. So I try to accommodate where I can, but also try to keep myself close enough to home, because I have to pay my way. Insurance doesn't, pay for mileage or that time it takes me to get to different places. So try to be accommodating best I can. Telehealth is also an option under several insurance plans as well. So if they're a person that is someone that can use technology or has a family member that can assist them with that, I can, try to assist virtually as well. That's not my preferred method, just because sometimes it's difficult for my folks, but whatever I can do to try to spread my wealth, I will do. All right, here comes my contact information.
All right.
So that anyone can get in touch with me anytime they wish.
Very good. And just want to reiterate this. So if someone is experiencing low vision issues, they would need to go to their eye doctor first to seek a referral, or can they go to their general?
Absolutely. They should definitely be following up with their general optometrist or ophthalmologist or their specialist, retina specialist. Definitely be keeping up. I know sometimes, they may say there's nothing more they can do for you, but they are monitoring the condition for any changes, especially with macular degeneration, watching for, if you have the dry form, they're definitely watching for any wet activity or if there needs to be any treatment. So it is important that they take a look at you, on their terms, whether that's 6 months, 3 months, 1 year, definitely be following up so that, yes, they can provide a referral when it's needed,
Okay. Well, again, this is Jennifer's contact information on the screen. If you know anyone who may be needing her services, feel free to reach out to her. But do just remember you will need a referral from a doctor before any services are able to be provided. So thank you very much, Jennifer, for being on with us today. We look forward to continue working with you on several of our patients, and thank you so much.
Thank you.
Have a good day.
You too.